Hello, everyone. My name is Arya Javidan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series. Today's session is on the Southern Regional Disaster Response System, a comprehensive overview, and is hosted by the Southeastern Telehealth Resource Center. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little bit of background on the consortium, located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few tips before we get started today. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please also note that closed captioning is available, and that's located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on our NCTRC YouTube channel. And with that, I will pass it over to Boyd Mark, Program Director for the Southeastern Telehealth Resource Center.
Thank you very much, Arya, for getting things going today. Very well done, as usual. And good afternoon to our audience, and thank you for joining us today on this webinar presented by the National Consortium of Telehealth Resource Centers. My name is Boyd Mark, and I'm the Program Director at the Southeastern Telehealth Resource Center, also known as SETRC. We are responsible for telehealth and virtual healthcare initiatives in Alabama, Florida, Georgia, Puerto Rico, South Carolina, and the U.S. Virgin Islands. And we have a really great program today. We're going to hear from the physicians at the Southern Regional Disaster Response Initiative, also known as SRDRS. They're from Emory and Augusta University. SRDRS is funded by Health and Human Services, and they have the mission of complementing the existing preparedness frameworks provided by the regional healthcare coalitions. And our speakers today, all physicians, will highlight the signature SRDRS programs, including telecritical care, tele-EMS, tele-observations, and more. All of these are designed and operating to increase regional surge capacity following emergency events. The speakers will tell you a bit more about themselves very quickly. I will let you know we have Dr. Michael J. Carr from the Emory University Rural Tele-EMS Network, Dr. Michael Ross from the Emory University Tele-Observation Service, from Wellstar MCG Health and Telecritical Care Services, Dr. Matt Lyon, and from the SRDRS Initiative, Dr. Alex Isakov. And I would be remiss if I did not mention Heather Miller from Emory University, who has been invaluable in making all this possible today. So with no further ado, I will turn it over to you, Dr. Carr.
Okay, I think I'm going next. You can go ahead and advance to the next slide. Again, Michael Carr, nice to meet y'all. And I'm on faculty in the Emory University School of Medicine. I work as a board certified emergency and EMS and disaster medicine physician in the pre-hospital and disaster medicine section. As it relates to this, I'm a principal investigator and the director for the Emory Rural Tele-EMS Network, which has developed a very recent partnership with the Southern Regional Disaster Response Framework. So we'll talk about what that partnership looks like. Next slide. Next slide. I'm going to hit on 5 major things, but just want to disclose first, ERTEMS, or the Emory Rural Tele-EMS Network, has been initially funded by HRSA, Health Resources and Services Administration. And of course, I'm obligated to say that everything I talk about in our grant project is not an endorsement by the US government. So next slide. Just 5 things, next slide. Sorry, I'm used to advancing these myself, so I apologize. But you know, I want to hit on 5 major things. The big 3 that I'm going to cover are really the why of our program and how we got started. I'm going to hit on our software connectivity and our equipment. I'd like to talk about our sustainability plan, especially as it relates to our partnership with SRDRS, really about SRDRS and then the vision for our ERTEMS integration into SRDRS. I'll touch on throughout my presentation, but these last 2, 4 and 5, are going to be highlighted in greater depth later on by Dr. Isakov. So I won't talk as much about them. Next slide. So first, our why. When we got this program started, it was early March 2020 when this was first conceived. We thought about the rural disparity throughout the state of Georgia and how we could use virtual care to support that disparity. In other words, how can we put equipment in the back of ambulances in areas throughout the state that have a rural designation where access to healthcare is unfortunately severely diminished. That access issue becomes a major problem for time-sensitive and time-critical conditions. Next slide. This is, next slide, thank you. This is presented in a way that I'm going to focus on kind of our challenges as they came up, and then really the success and the outcome that we are currently functioning under. Next slide. This is a multifactorial problem that I'm talking about. The rural disparity is historically as a result of rural hospital closures. When a rural hospital closes in a rural county, all of a sudden we remove an access point to the healthcare system. So if you can picture calling 911 in one of these counties, it takes a lot longer for the ambulance to get there in many cases, but really to get from the scene of where that call was made to get to the closest hospital, oftentimes in many of our counties, we're looking at 30, 40, 50 minutes to get to the closest, most appropriate facility. And in the setting of a time-sensitive or a time-critical condition like STEMI, stroke, trauma, high-risk labor and delivery, sepsis, undifferentiated shock, these are all conditions that we know the longer it takes to get to definitive care, the worse our outcome is going to be. So, think about that from a problem perspective. How can we use virtual care to support that problem and that disparity? Next slide. In a nutshell, if we put, which we've done, we've put telemedicine equipment in the back of ambulances, which I'll show you some visuals of how that looks. But a rural EMS crew can call in and speak directly to an emergency physician. With patients who have these critical time-sensitive conditions like STEMI, stroke, trauma, they are immediately connected with an emergency physician to weigh in on treatment guidance. Certainly these EMS personnel, they have protocols that they can follow, but these patients are complicated. Not all of these patients read the protocol manual, right? So that physician can help kind of pull the pieces together and we can weigh in on clinical guidance. But probably the second leg or the right-sided component of this diagram is the most valuable service that we provide. We are able to facilitate that patient's care with the receiving, often small rural hospital or critical access hospital. In other words, I always use the example of a stroke. We can call in and say, hey, you're getting a stroke patient. They're 20 minutes out. Here's all their information so you can get them registered before they arrive. Go ahead and clear your CT scanner table so that we can scan this patient as soon as they get there. And by the way, give me the number for your on-call neurologist. I will call and give them the story so that they're ready to go by the time that patient is evaluated. So in the setting of a time-sensitive ischemic stroke, all of these facilitation actions that we're doing are really improving that time to definitive care for the patient. Getting the emergency physician involved earlier in many ways is going to help facilitate that downstream care. And I want to point out that the biometric data from the back of that ambulance, everything we're seeing on a monitor, can be streamed in real time to that emergency physician who's up in a control room at Emory University or in Atlanta. Oftentimes, these physicians are also working from home doing telemedicine work. So we can see all of that data from the monitor, and we can also share that information with the receiving hospital. Next slide. Our current footprint, in terms of our rural coverage, and also we've added a few counties to fulfill the disaster response framework initiative. All of these highlighted counties have an ambulance deployed with equipment. Most of them are online and able to call. Many of them we're still kind of onboarding and bringing the crews up to speed and configuring our equipment. Next slide. We have a plan to expand to the additional highlighted counties over the next year with a hope of really fulfilling or meeting the goal for SRDRS, which is to have an ambulance present in every hospital coordinating region throughout the state. Next slide. Long term, we hope and plan to expand and develop this model throughout the Southeast. Now with our SRDRS partnership, this model we see being replicated in states throughout the Southeast region in HHS Region 4. Whether or not that's a hub and spoke model with Emory and Augusta physicians answering the call for other states, or they replicate our hub and spoke model in their state and we service support, infrastructure support. I think there's going to be a lot of variety in how that model looks from state to state. Next slide. A bit on software and equipment, and I know I'm under the gun here, so I'll try to wrap this up quickly. Next slide. We have exceeded our initial goal of 30 ambulances. We have a software vendor called SWIMED that specializes in delivering telehealth in rural and austere environments. And that software has really helped us pull everything together. Next slide. We use DT Research tablets. We use an Axis pan-tilt zoom camera. We have a Yamaha speaker mounted on the side of the ambulance. And we've mostly integrated with Zoll X series monitors. That being said, we've started to develop relationships with agencies, and we are integrating with other monitors. Now, that of course is very difficult when you have multiple competitors across the market. We want to be able to work with everybody so that we can touch as many agencies as possible. Next slide. You can advance through these just to give a visual. So here's the tablet. We have a pan-tilt zoom camera mounted up in the ceiling. We have a noise canceling speaker mounted on the side. Zoll X series monitor can integrate via Bluetooth with our software, which you see here, where vital signs can be displayed in real time during that call. Next slide. So I always get questions about our connectivity. We're primarily using cellular. So Verizon and FirstNet AT&T are primary providers. That being said, then this is a problem for tele-EMS programs all over the country and world. Connectivity is probably one of our greatest barriers. In many regions, what happens is the antenna has on an ambulance doesn't have enough power or gain to really see the closest cellular tower. So there are potential solutions where we can get higher gain antennas to add to the top of the ambulance to enhance our cellular connectivity. Satellite in its current form is just not good for a moving target. And we're seeing, ambulances are a moving target. Satellite, I think that technology will continue to improve. You can advance to the next slide. Especially with companies like Starlink working on mobile solutions for satellite coverage. There's satellite switching technology that's increasingly available in the commercial environment. So we're going to see satellite, and I think higher gain antennas really make their presence within our network so that we're really able to highlight that connectivity. Next. Sustainability real quick, and this is really just speaking to our partnership with SRDRS. Our financial viability in ERTEMS relies currently on a number of different models. Fee for service in our current environment is just not gonna work. So subsidizing our network with government, with additional grant support is really going to be a key component to moving forward. Next slide. Real quick, our current work that Mike Ross is going to highlight is also covering the physicians who are covering teleobservation and teletriage in our network. Those physicians are also able to answer EMS calls. So that's kind of how we get around having to fund a dedicated physician, and that contributes to our sustainability. Next slide. And that's me working a teleobservation shift. Next slide. You can advance quickly through these just to give a visual representation of our state-funded model, state-funded plan. As we continue to build out our sustainability, there's going to be a multifactorial approach to this. So you can advance through these next slides because that will tee up Mike Ross to talk about our integration. If you need more info, you can certainly QR that to get more info on the program. And I'll hand it off now to Mike Ross.
Wow, that was a whirlwind. Thank you, Mike. It's always great hearing you summarize your program. Mike Ross, Chief of Observation Medicine, practicing emergency medicine at Emory, also Director of Emergency Virtual Care for the Department of Emergency Medicine. Next. So telemedicine is simply a tool that we use to manage our patients. Let's talk now about how telemedicine has been developed and adopted at Emory to manage observation patients. And then furthermore, how that in turn can be used to, for disaster preparedness. We'll cover a background on what it is, observation medicine is, talk about teleobservation and the evidence behind it, and then wrap it up with disaster preparedness and what I believe is a win-win. Next. So there's often confusion with observation because it's both a verb, a noun, and an adjective. What I mean is observation patients, what I call 6 to 24-hour patients, are people that need care that's beyond an ED visit, but not quite an inpatient stay. Now, the payers define observation services as management to determine the need for inpatient admission. Notably, these patients represent 20 to 35% of all patients staying in any hospital. Now, where they're cared for is defined by, for the setting, is defined by two variables, the use of protocols and the use of units. So if you have a protocol-driven, dedicated observation unit, that's a type 1 setting. No protocol, no unit, Wild West, that's the type 4 setting. Unfortunately, for 2/3 of hospitals in the US, there's no observation unit. The type 4 setting is the only setting available. Next. Now, there have been 9 prospective randomized controlled trials showing the superiority of a type 1 setting over a type 4 setting for conditions such as syncope, chest pain, AFib, TIA, asthma, with outcomes such as lower admit rates, lower costs, improved clinical outcomes, less diagnostic uncertainty, and improved patient-provider satisfaction. Next. So to help get our head around this, let me tell the tale of 3 hospitals. Next. For what works and what doesn't. Hospital A is a scenario where observation patients, indicated by the blue beds in this graphic, are scattered throughout the hospital, mixed with inpatients. Very representative numbers. Their length of stay will be about 33 hours. Their cost per case about $1,978. Next. Now, Hospital B might take those patients and cohort them on an inpatient unit and manage them by protocols, thereby decreasing the length of stay to, say, 28 hours and cost about $1,800. Next. In Hospital C, you take it a step further and move those outpatients completely out of an inpatient setting, in a setting such as an ED-run observation unit, where the cost per case comes down to about $1,342, and the length of stay comes down to 17 hours. Next. Now, as you can imagine, if you run the math on that, comparing Hospital C with Hospital A, Hospital C will save, using a hypothetical hospital with 3,000 observation visits per year, Hospital C will save $1.9 million per year in cost alone. Not only that, if you total the hours and divide by 24 to give bed days, Hospital C will save 4,125 bed days per year. With the contribution margin of a bed day being $1,000, it'll bring in, between cost savings and revenue enhancement, it'll realize a $6 million benefit per year. Next. Now, are these hypothetical imaginary numbers? No. Let me share real world Emory data with you for 4 hospitals within our system that manage both type 1 and type 4 settings. For those 4 hospitals, over the course of a year, they saved $24.8 million in cost. They opened 10,526 bed days. Not bad for a day's work. Next slide. And these differences are not, it's not a one-off, they're sustainable. I've graphed them over time. There's consistently about a 24-hour difference in length of stay and about $1,000 per case difference in cost. Big impact on hospital operation, no matter what size hospital. Next slide. So for hospitals, it's great. For physicians, it's not always so great, because with emergency physicians, their ability to bill for this service is driven by some nuances of physician CPT codes and a critical number of beds. Next slide. In this study, which I won't get in the weeds, but where we basically showed that for physicians to provide the service in a financially sustainable, not a cash cow, but just breaking even, financially sustainable level, there needs to be at least 20 beds. Next slide. So herein we introduced telemedicine. Now, telemedicine, as mentioned, is a tool used in medicine for things like clinic visits, critical care visits, emergency visits, and now also observation visits. It helps hospitals maximize use of resources, be equitable, provide better care. Next slide. When the pandemic hit, we were working in teleobservation. We now provide a full spectrum of telemedicine services for emergency medicine with tele-EMS, as Dr. Carr has described, a direct-to-consumer nurse call line service that we staff now, and tele-CD, which I'll talk about now. Next slide. What we've done is we've taken, of our 4 observation units in this scenario, we've taken 2 high-volume observation units and had the physician staff those 2 units with 1 provider, 1 physician, giving a combined number of beds of 29 with a total number, an annual census of 8,713 patients. Now, thanks to the support of the SRDRS grant, we are expanding. We're about to double. We're expanding that program to 2 more hospitals, which will give us, again, a combined census of 22 beds and 7,295 patients. Next slide. So it's very simply the way it works. The physician comes to his or her shift. They sit at the computer, as indicated in the top left picture, and the APP in the observation unit, we call it the CDU, they turn on the rounding cart and they round at the desk. After rounding at the desk, they go room to room with the cart and they see all the patients, discussing plans, answering questions. At the end of rounds, the physician rounds in the second unit. At the end, they help co-manage patients in these 2 units for the duration of their shift. Next slide. We have been doing this for 3 years now. January of this year, we published a non-inferiority study where we showed that virtual rounding in a type 1 unit is non-inferior to in-person rounding for a sample of 20,861 observation units. Non-inferior in terms of the patient length of stay, the inpatient admit rate, the cost per case, or adverse events defined as ICU admission or index visit death. Next slide. This slide gives the details, which again I won't get into, but they're available. That shows the breakdown of the control that we used and the difference over time. Next slide. What we're working on now is what I call the superiority study, which is the benefit of teleobservation relative to traditional care in a type 4 setting in an inpatient bed. In this sample of 2 hospitals over 2 years, tele-CDU versus traditional inpatient care type 4 setting, over 2 years, the saving is $52 million, and the bed days saved is 17,547 bed days. Again, not bad. Next slide. So this is good for, it's non-inferior, it's a non-inferior practice model. It's superior to traditional inpatient care. It addresses a lot of physician staffing issues, and more importantly, it helps a hospital prepare for disasters. Next slide. In my career, I've seen 6 examples where just as the ED is a safety net of the healthcare system, the observation unit served as the safety net for the ED in the setting of a disaster. There were 2 inhalation disasters, 2 environmental disasters, 1 epidemic, and 1 pandemic. In all cases, the observation unit was leveraged to help the system prepare and accommodate the sudden influx of patients that came with the disaster. Next slide. Again, thanks to the support of the SRDRS grant, we're developing a model where a hospital can adopt a type 1 observation unit using telemedicine equipment, a tremendous advantage to the hospital in terms of cost and operations. But more importantly, by having daily use of telemedicine equipment, when a disaster strikes, they have that equipment running and ready to use. We're developing observation unit protocols for unique CBRNE, chemical, biological, radiation, nuclear, environmental disaster patients for things that physicians don't generally treat, like radiation sickness. Because if you think about it, with any disaster, with that sudden influx of patients needing hospital care, there's going to be a sizable portion of those patients that need 6 to 24 hours of care. Where if you manage them efficiently, they can be discharged safely and appropriately if that's what's needed. Better than putting them tying up in a hospital bed, tying up in an inpatient resource. Number 3 is this provides immediate subject matter expertise for the unique conditions that emergency physicians don't routinely treat, like radiation sickness, chemical injuries, and biological injuries. And in that context, it provides flexible staffing, a pool of physicians that can suddenly be deployed to help cover these disaster patients. It brings in subject matter experts for these things, and it preserves scarce resources such as PPE and inpatient beds. Next slide. Well, with that, I'll turn the mic over to Dr. Lyons.
Oh, hey, everybody. I'm Matt Lyon. I'm from Wellstar MCG Health, Medical College of Georgia. And we're going to talk about our rural hospital virtual care network. And very similar to the why Dr. Carr expressed, and the also the how you use it disaster that Dr. Ross talked about. We're going to talk about how our program helps rural hospitals take care of rural patients and also is helpful in a disaster. Next slide. So it all starts with the rural community hospital. Next slide. With a rural community hospital, what you find is that there's, smaller populations, otherwise they wouldn't be rural. That means there's less businesses and there's less economic resources in the community. Because of this, there's often less physicians and other healthcare resources. And because there's less resources immediately available, and as Dr. Carr said, time-sensitive conditions and distance are two bad things to combine, you often have worse healthcare outcomes. And because you have less quality of life, you often have people leaving rural counties, rural towns to move closer to city centers. There's also other health disparities that come in with this, which leads to less life expectancy in rural counties, which then feeds back into a smaller population. Next slide. So what I like to, the way I like to describe this a little bit differently is the negative revenue cycle. So a rural community hospital often doesn't have the resources they need to take care of the patients that are seeking care at their hospital. Because they have less resources, they often transfer patients to other hospitals. This is necessary in many cases. You don't have a cath lab, stroke, STEMI, capabilities, but it also leads to a mindset, which is we're going to transfer this patient because we're afraid that they're going to get sick. Because you're transferring more and more patients, you have decreased revenue in your hospital. You're unable to reinvest in equipment and people. And so it's a self-fulfilling cycle that you often end up with less resources over time, which decreases your capabilities over time. Next slide. This has a dramatic effect on the rural disparities we just talked about. Because you have less resources close to home, you often have delays in seeking care, whether that's for an emergency or for chronic medical conditions, which leads to a higher incidence of poorly controlled disease. It also, as Dr. Carr explained, you have a decrease in the ability to take care of emergency conditions locally. So you have an increase in delay in taking care of those conditions and delays in specialty treatments. There's also less coordination in care because you're transferring from your local community to another city. That coordinated care between the specialist, the primary care doctor, and the rural community, and maybe even the health system, it's just not there. So you can't get people through the cycle of their disease and making sure they don't have readmissions. And ultimately, this leads to higher morbidity and mortality in the rural community or the rural-urban disparity in healthcare. Next slide. So what we are going to talk about for the next couple minutes is a rural community hospital focused telemedicine program. Next slide. So again, we have that negative revenue cycle. So our goal here is to decrease unnecessary transfers. And this is a moving target or a moving goal because what we want to do is we want to keep more and more patients in the rural hospital. That's where the patient was going to seek care. And so if we can prevent a transfer, that's going to have a positive impact over time. The more people we keep in the rural hospital, the more people they can submit bills on, the more income they have. And when they reinvest in themselves with that increased revenue, they have increased ability to care for more and more complex disease. Patients also see that they're partnering with a larger health system, that they're getting great care in their rural community, so they don't bypass that hospital as much, which then means they have more timely care and the hospital has more revenue. And this increases the community health care paradigm, which then feeds back on itself. And this is a spiral up instead of a spiral down. Next. So what we have created, what I call it, is our rural hospital virtual care network. We take care of patients anywhere from triage to discharge in that rural hospital. It's anywhere. It's not just in the emergency department. We divide that for us in different buckets because it's the way we kind of think about things. It's easier for people to think about the continuum of inpatient being in the hospital, the ER being part of that, and then the outpatient being clinic. But really, it's really a continuum anywhere in there. And we're using telemedicine in that ecosystem to provide connectivity to specialists at an academic care healthcare center. Our goal is to decrease healthcare disparity, and that's primarily by keeping low complexity patients in the rural county hospital. If it's exceeding what we can do by telemedicine, or if it's exceeding what the hospital can provide, then we expedite those transfers to a higher level of care when necessary, which then helps decrease that delays. We are also working on that coordination of care. We may talk about that just for a minute if we have time, but trying to work with the rural hospitals so that the patient is not lost to follow-up, not lost to that specialist. So they're getting timely follow-up care. And then the last part, which is really important, is providing educational support for those practitioners in the rural hospital, whether it's the clinicians, the nurses, the respiratory therapists, the pharmacists, so they feel comfortable taking care of more and more complex patients. Next slide. So it's just a few pictures here, but again, I wanted to emphasize this is anywhere from triage to discharge for that patient when they come into the rural hospital. We use a variety of technologies. We connect via audio and video using a Cisco codec, and we have both carts and on-wall equipment. We're able to see into the patient's room. We can also connect in some of our hospitals to the monitors, so we can see the hospital's monitors real-time remotely, along with our video, very similar to what Dr. Carr was showing you in the ambulance. So that allows us to make really good clinical decisions on their patients. We also, the bottom right down here is a patient that the helicopter had to come in to intubate this patient from the left to the right. And we used the Emory was the medical director for this. So we had a little negotiation between Augusta University, Emory, and us to take care of this patient. Next slide. This is a list of our hospitals where the red dot there in Augusta, Atlanta's off to the northwest there. You can see that our hospitals are mostly south and west of Augusta. So coming out of Augusta and going down towards the south, down towards Savannah, and then left towards Albany is not only some of the worst healthcare outcomes, the highest healthcare disparity in Georgia, it's some of the worst in the United States. So we're targeting hospitals where there's a lot of disparity primarily, and trying to make this connection. Next slide. Our program does come in phases. It does take time to build that positive revenue cycle because we have to establish relationships. So we generally start in the emergency department to avoid unnecessary transfers and expedite transfers when necessary. That's a really easy place to start. But the largest place, the biggest impact we have is on the inpatient, which is more phase 2. So we're starting to provide, starting to fill that complex care gap to provide that knowledge to those inpatient providers so that they will be willing to keep those patients in the rural hospital. After we get through that phase, then what we try to do is increase the average daily census in a rural hospital by returning their transferred patients back to them for swing bed and rehab and those type things. And then phase 4 is regional care coordination between those hospitals and us, Emory, Savannah. We work to try and make sure that that patient doesn't get lost through the state because their specialist is in another part of the state from their rural hospital. Next slide. These are a little bit out of date, a month or two out of date. We've seen nearly 3,000 patients in this program, nearly 10,000 encounters. Our overall transfer rate is around 28%. When we were taking more of COVID, it was down at about 20%. But this is not a bad thing. What this is showing you is that over time, we have more and more complex cases being at least initially treated in the rural hospital, some of which are going to require services that have to be at a higher level hospital. And so I'm proud that actually that our transfer rate has actually gone up a little bit because that shows that our complexity is increasing. We also look at each individual hospital with their case mix index, and we can see that their case mix index is also rising to correlate with this. We don't always transfer to us. You can see that in the next line. We transfer to wherever is the best place for that patient. If they already have an established relationship at a hospital, that's where they go. And then end of life care, it's a little less now that COVID has decreased some, but you know, it's better for a patient to have that end of life care in their home community. Next slide. So this is just a couple quotes. One I'm going to point out is just in the bottom right. Candler County Hospital is Metter, Georgia. It's about a little over an hour south of Augusta, in that kind of belt that I was telling you had poor healthcare outcomes and healthcare disparity. They in 2018 were listed as the #2 most likely hospital to close in Georgia. They had approximately an average daily census of about 4 to 6 patients. After we've brought in telemedicine, and also they brought in a new hospitalist group committed to using telemedicine, we've increased their average daily census to over 20, sometimes even closer to 30. And their case mix index has gone from 1 to about 1.5. That's resulted in a 35% increase in the net revenue and a decrease in transfers by over 50%. So this has had a major impact on their operating margin. And I can safely say they're not on that risk for closure list anymore. Next slide. So how does this help in a disaster? Well, you've heard a little bit about this from Dr. Carr on the EMS side and Dr. Ross from the observation side, and it's very similar to both of those. So if you can augment those rural hospitals with telemedicine to increase their complexity of care, you increase their revenue, then they have more equipment and they are able to invest into disaster support. They're able to invest then in better trained staff. We're able to tie into them with education so we can deliver them disaster education so that they are up to date on what they should do. It also helps with connectivity, like Dr. Ross said. If you're using this daily, then something bad happens, you're able to just flip a switch. You know what to do. It's ingrained in you. You know how to get that coordination. So that allows you an immediate connection with specialists, maybe the poison center, so that they can help you in that disaster. It also helps you with surge management from a statewide perspective. We have 16 rural hospitals. If a disaster happens in one of those hospitals and our academic centers or our tertiary level hospitals are starting to have capacity issues, we can also assist in another hospital, a rural hospital where they may not have normally been transferred. We can come in and help them. We also understand those rural hospitals' capabilities. So if a disaster happens in a rural county, we know how much capacity that rural hospital has and what their capabilities are, and we can stage those transfers out of that rural hospital. And again, I can't overemphasize, but that avenue for education and training, once you have that relationship, then we can help augment them over time. Next slide. And so this is just our QR codes if you want to learn a little bit more about this, and thank you for listening.
Thanks, Matt. All right, I'm the anchor. You guys are definitely smarter about telemedicine than I am, but I want to let the audience know how this is all wrapped into the Southern Regional Disaster Response System and what that is. I'm Alex Isakov. I'm an emergency medicine and EMS physician at Emory. I'm the director for our section of pre-hospital and disaster medicine within our Department of Emergency Medicine, and really grateful to represent the executive committee of the Southern Regional Disaster Response System. These are principals from Emory University, Wellstar MCG, the Georgia Department of Public Health, as well as the University of Georgia's Institute for Disaster Management. Next slide, please. And for those who may not be familiar, this is an initiative funded by the Administration for Strategic Preparedness and Response. This is a grant funding mechanism called the Regional Disaster Health Response System grant mechanism, and we were the fourth region in the United States to be awarded this grant. The first two were awarded in regions 1 and 7, I think in 2018, and in 2020, there was an award in region 8, and we applied and were given this award in 2021, and again, grateful for Drs. Lyon, Carr, and Ross being partners in our efforts to improve the capabilities and capacity for management of patients that would come as a consequence of a CBRNE incident in the Southeast states through telemedicine capabilities. Next slide. There are broad aims of the SRDRS. Largely the aim is to improve management of patients that would come from a CBRNE incident, improve access to clinical subject matter expertise, improve capacity for management of those patients. And some of the ways in which we hope to do that, you heard described through these various telemedicine programs. Just broadly on the augment, improve, and facilitate, in putting our collaborative group together, we certainly wanted to serve as champions for existing public-private partnerships that are in our region to access their clinical subject matter expertise and their knowledge of the care of complex patients. And that includes some programs that we'll talk about later that are also federally funded, the National Emerging Special Pathogens Training and Education Center, for example, or regional special pathogens treatment centers, the poison control centers, radiation injury treatment network hospitals, and we'll go over that in a bit. We also have initiatives to try and improve bidirectional sharing of information, largely through efforts at development of model medical operations coordination centers or cells across the Southeast region, and of course, facilitating greater access to clinical subject matter experts through telemedicine and other means. Next slide. So we'll get into a little bit more detail, and briefly describe some of our regional partnerships. We'll talk about one of our major initiatives in the development of medical operations coordination cell capability in the Southeast. Of course, expansion of telemedicine systems, and then the development of a repository of resources for CBRNE mass casualty management. I think on the, since this talk is largely aimed at how telemedicine systems can be used to augment the ability to care for patients that would come from a CBRNE incident. I just want to really underscore and the ways in which these telemedicine programs do augment our ability to manage CBRNE casualties. And you've heard this already in some ways from Drs. Carr, Ross, and Lyon. But let me say that as a program that started in Georgia, the Southern Regional Disaster Response System, but has a geographic scope of the Southeast region. What you heard today from these three clinicians and experts in telemedicine are ways in which telemedicine capabilities, whether it be for tele-EMS, for teleobservation, or for telecritical care, have been implemented for day-to-day use to address the needs of patients in our communities, using technology, but also the clinical subject matter expertise at the health systems that are contributing to the development and ongoing maintenance of those telemedicine programs. And then there's a commitment by those programs to also develop the concept of operations to pivot that capability to the needs of CBRNE casualties. And we know that there's not nearly enough capacity in any one single health system to manage the numbers of casualties that you might expect from those types of incidents. And so developing capabilities that expand the capacities to do that through telemedicine in the ways that you just heard described by Drs. Ross, Carr, and Lyon, and plugging the needs of the patient with the right clinical subject matter expert is one of our objectives and initiatives. That ability to take sustainable programs, use day-to-day, for which a good business case exists actually for their sustainability, and getting the commitment to pivot that capability to the needs of CBRNE patients is really one of the foundations of our program. Next slide. I mentioned the development of medical operations coordination cells. We started working with our partners here in Georgia. The Georgia Coordinating Center is an initiative funded by the state, really to better match the needs of patients in the pre-hospital setting being transported by EMS with the capacities and capabilities of hospitals in a service area or region. Through that center, there's some visibility on the demands for services in various emergency departments. There's an understanding about where patients are being engaged by the EMS service, and there is a day-to-day use model for that center to best match the patient with where capacity exists for them to be cared for. We're working with our partners there to really utilize their communications availability and some technology that they've made investments in to enhance our ability for patient distribution through after a CBRNE incident as well. One thing that is clear and actually reasonably well documented during COVID is that there's an excess mortality associated with hospital surge. Hospitals that are trying to deliver care really beyond their capacity to deliver experience some excess mortality because of the surge. And the Administration for Strategic Preparedness and Response recognizes that and is really a strong advocate for the development of medical operations coordination cells. Our work with the Georgia Coordinating Center to develop some of those capabilities is one example. But as we reach out to partners across the 8 Southeast states, we're really looking for other medical operations coordination cells capabilities that we can learn from, that all of our partners across the 8 states can share experiences from, and then also work to develop some new linkages between those centers so you have a more regional approach to patient redistribution when there's a surge in a particular community. Next slide, please. On the issue of using telemedicine or other technologies to address needs of CBRNE casualties, we work to develop regional collaborations with subject matter experts that have the knowledge and expertise to manage patients that have suffered a chemical injury or a radiation injury or bomb blast explosive or a bio threat. This regional collaboration of Region 4 Poison Control Centers, led by our Associate Medical Director for the SRDRS, Dr. Ziad Kazi, who's a clinical toxicologist at the Georgia Poison Center, is an example of that, trying to develop dialogue and coordination across the 10 regional poison centers that we have in HHS Region 4 to better manage a volume of patients and provide the appropriate clinical subject matter expertise for their management at hospitals, both in the community or those that would hold out, capabilities as academic health centers. Next slide, please. Another example of working to develop regional collaborations for patients with radiation injury beyond the expertise of the clinical toxicology groups within the poison control centers in the Southeast is trying to leverage the clinical subject matter expertise represented by the Radiation Injury Treatment Network hospitals, who have through arrangements committed to care for the sickest of patients that would come as a consequence of a radiation or exposure to ionizing radiation, but are also are home to significant clinical subject matter expertise that can help inform the care of those patients in community hospital setting as well. Next slide, please. I'd mentioned previously our relationship for biothreats with the National Emerging Special Pathogens Training and Education Center. Emory University Hospital is one of the principals for that national initiative, funded also by the Administration for Strategic Preparedness and Response in the Department of Health and Human Services. And within Region 4, we have 2 federally designated regional special pathogens treatment centers, one at Emory University Hospital and one at UNC Chapel Hill. And it's through the network and the development of relationships that that this initiative that we're tied to is developing across the Southeast, that will have access to the clinical subject matter experts necessary for managing consequences of a bio threat. Next slide, please. Again, this is a very high-level interview. There's 10 minutes left in the hour, and I know we want to provide opportunity to answer questions. But largely what the regional special pathogens are, so largely what the Southern Regional Disaster Response System is doing is from a core group of initially funded partners seeking additional partners across the HHS region for clinical subject matter expertise in bio, radiation, chemical exposure, trauma and burn, to have a more collaborative opportunity to better manage patients and the large volume of patients you might have from those types of incidents. As described, the telemedicine programs are a major and significant tool or strategy to increase access to clinical subject matter experts and provide the guidance that's necessary for hospitals across the Southeast region to care for those patients in their local community and transfer those that are most appropriate for transfer. Next slide, please. I think this brings us, Boyd, to our question session. So thanks again for everyone's attention and for including me in the presentation.
Thank you, all of you. Really excellent information. And we do have a few questions. Some of them have already been addressed, but so everyone can hear the answer. First one to Dr. Ross regarding the ED-CDU observation studies. Could you briefly address that? And we'll also make sure people have access to getting that information.
Sure. This is easy. If you want to know how the unit operates, just Google Emory CDU manual, and our 65-page manual for how the unit operates will come up. As far as studies, there have been a lot of studies. It may be easiest if you email me, but there's a kind of a review paper called The History, Principles, and Policies of Observation Medicine, published by yours truly, Mike Gronowski, a few years ago. That's really a nice overview. There's some other reviews of observation medicine. For disaster preparedness, Heather Miller is working with the team to prepare a kind of a disaster preparedness manual that will have a lot of the observation protocols that we're referring to. We're also preparing a manuscript summarizing the role of observation units in disasters. That's not published yet. And by the way, if anybody has a similar experience with an observation unit disaster, please send it to me and we'll add you to the review. But those will probably be the two main things: Heather's paper and the Emory CD manual. If you want literature, email me, I can send you references.
Thank you. Second question we have was for Dr. Carr, and I will summarize it just slightly. The question is, what are your views for use cases on the other end of the spectrum, namely low acuity treat in place to reduce unnecessary transports?
Absolutely, and this is a great question that I frequently get, and it's very reasonable. I mean, when we look back and think about tele EMS networks, we've all kind of thought about this individually, right? At least those of us who in EMS who are really excited about this stuff. We've thought about how virtual care could support EMS systems, and low acuity treat and release, alternative destinations to the emergency department comes up as something that would really benefit the system. In the current landscape of EMS, most agencies rely on the transport to the hospital to generate revenue. So in many ways, I think the capability is there. But especially in our rural markets, we don't want to incentivize EMS crews to call in when an agency may be relying on that transport to the hospital to get paid, right? And to continue to function. That being said, I think this is an important point. The goal for us is to build the network and build the infrastructure. When we hopefully see an ecosystem where EMS reimbursement changes and alternative models of care are reimbursable, we'll be ready to go. And I think there are markets where we've been asked that, to support low acuity treat and release and alternative destinations. But we're not there yet. And I really hope in the near future, we'll get to a space where we can start to use the network for alternative treatment models such as that.
Very good. Thank you for that information. I'd like to touch on something while we have a couple of minutes left. Dr. Lyon, you mentioned that you might want, or you might have a couple of additional remarks around better care coordination and the benefits of that. Would you like to address that?
Yeah, just, if you think about in your own health system, the difficulties of getting a patient from an acute care into a clinic, it can be a little bit of a challenge when you start thinking about then a rural patient having to be transferred to a city and then getting them back to their home. Some of the things that we're working towards is working with rural social workers, connecting them to our social workers so that they can make sure that there's no drop between there, connecting our pharmacy with the patient's pharmacy to make sure that the medicines are provided. And then our future is in-home telehealth coordinated care so that you're really making sure that these transitions of care happen appropriately.
Very good, thank you. And certainly we're all mindful of the opportunity to reduce readmissions through better care coordination and the benefits that has for patients as well as for the health system. Dr. Isakov, if someone out there wants to get more involved, what would be their steps to go through?
Oh, thanks, Boyd. Pretty straightforward. If you look at the slide that's being presented now, you can send an email directly to SRDRS@emory.edu. You can also go to the website and put in a query or an outreach message for collaboration. In some cases, perhaps some audience members here will have already received an engagement tool, something of a survey to see if you have active telemedicine programs or active medical operations coordination cells in your community. We'd love to hear from you and partner with you and link your teams to our teams. Probably the safest thing would be to send a message to SRDRS@emory.edu.
Excellent. That's a very clear and understandable path for everyone. Thank you. Well, gentlemen, this has been an outstanding session. Thank you for your time. A lot of good questions. This is really great work, utilizing telemedicine in various ways to address some of the most important challenges we have facing our communities and ensuring that people have access to healthcare when they need it, urgently, over time, longitudinally. So thank you very much.
Thank you, Boyd. Thank you, everyone.
Thanks for having us.
Thanks.
Thank you, Boyd.
See you next time.
Just as we close the session, just a reminder that our next webinar will be held on Thursday, November 16th, and that will be hosted by the Southwestern Telehealth Resource Center. Registration information is available on the consortium website. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to Dr. Carr, Dr. Ross, and Dr. Lyon and Dr. Isakov for their presentation today. And thank you to the Southeastern Telehealth Resource Center for hosting today's webinar. Have a great day, everyone.
Thank you.
Thanks.